Well, good afternoon, everyone, and welcome to the Concord Bookshop and to this afternoon's author event with Doctors Lena Wen and Josh Kosowsky. So I'm going to ask for a show of hands, how many of you have ever felt rushed to the doctor's office? Wondered why a particular test was ordered but didn't get an answer if and when you dared to ask? Felt like you weren't really being heard, that your answers to questions were just individual yes or no bubbles, like on a multiple choice questionnaire, rather than being part of a look at your full picture as an individual? Well, unfortunately, as you saw with the hands raised, you are not alone. Doctors Lena Wen and Josh Kosowsky assert that because of the red tape of our healthcare system and the current doctor training methods, medicine is no longer a thoughtful engagement between doctor and a patient. Instead, each patient's unique story is reduced to a simplistic kind of one-size-fits-all treatment based on whatever it is that brings them in, their chief complaint that day. Doctors no longer are empowered to listen, and patients are often misdiagnosed or, unfortunately, never diagnosed correctly at all. These doctors are ER physicians at Brigham and Women's Hospital, and they teach at Harvard Medical School. Their experience has shown that patients can become their own best medical advocates or advocate on behalf of their children or elders who are in their care. In their book, When Doctors Don't Listen, Doctors Wen and Kosowsky outline 8 pillars to better diagnosis. These are concrete steps that patients can take to work as a partner with their doctor to help them reach the correct diagnosis. By encouraging patients to advocate and participate fully in their medical care, we can improve individual medical care as well as lead the way to meaningful health care reform across the nation. This afternoon, the doctors will speak a bit about their experiences as ER doctors and listening to patients. They'll discuss the needs that they saw and the impetus for writing this book. Then I'll pull the podium back and they'll invite you to ask questions before they break to sign copies of their book, When Doctors Don't Listen. So please do help me welcome Doctors Lena Wen and Josh Kosowsky.
Well, thank you, Dawn, for welcoming us to such a wonderful bookshop on this day, and really want to thank all of you for being here as well, for coming to us talking about When Doctors Don't Listen, how to avoid misdiagnoses and unnecessary tests. You know, we are very privileged as physicians to learn the stories of our patients, to hear the stories of our patients. And so I want to start us off today by telling you 2 stories, because I also want to illustrate why it is that we wrote this book. What was the impetus for us in deciding to write a book about doctors not listening or about patient empowerment? What is it? So let me tell you. The first is about a young mechanic in his 40s named Jerry. He comes to the doctor because he doesn't quite feel well. He thinks that maybe he pulled something in his chest. He was moving boxes over the weekend, and everything was sore, arms were sore, legs were sore. We also felt like something wasn't quite right with his chest. And so he comes to the ER, and the doctor says, "Oh, chest pain. We need to make sure that you don't have a heart attack." So he gets an EKG done, and chest x-rays and blood tests. He has to stay overnight. Then the next morning he gets chest x-ray, EKGs, more blood work done, runs on a treadmill. And at the end of the day, the doctor says, "Congratulations, you don't have a heart attack. You have chest pain." And he says, "But I came to you with chest pain. I don't understand. Why are you giving me the same diagnosis as what I came to you with? Why can't I find out what's going on?" All right, then there's Danielle, who's a college student in her 20s. She had a bit too much to drink the night before celebrating her friend's birthday. And she comes in and says that, she has a headache. Of course, the doctor then says, "Well, I want to make sure you don't have something really bad." So he orders a CAT scan and a spinal tap. And Danielle says, "Why? What is going on? My doctor didn't even listen to me. Why do I really need these tests?" And so you heard Dawn ask at the beginning about how many of you have ever felt like your doctors just aren't listening, that they're using this checklist of, do you have chest pain? Do you have shortness of breath? Do you have headache? Rather than actually meaningfully listen to your story. And that's something that unfortunately we hear more and more, that patients are dissatisfied and frustrated about the care that they're getting. And and I know that that's not the way that medical care is supposed to be, right? And we hear all the time about, in the news, about the personalized care movement, how everyone's supposed to get their care tailored to their genome and your specific DNA. It's definitely not supposed to be that you can't even get your doctor to listen to you. And so what I want you to think about then is, if you can't even personalize care, in your individual interaction with your doctor, then are you really getting the best care possible? Are you really getting the care you deserve if your doctor never listened to your individual story? Every day we hear the call for healthcare reform, right? We hear about Obamacare, accountable care. It's in the news every day about how there are $2.7 trillion spent on healthcare, 18% of our GDP, and yet still in this country, we are ranked something like 50th in all the world in terms of healthcare quality. We also know that a third of all healthcare cost is waste, to the tune of $700 billion. $700 billion of unnecessary tests and unnecessary treatments. Doctors spend less and less time with their patients, and incentives, we know, are also not aligned right, so that the hospitals and doctors make more money with more treatment, not necessarily with better outcomes. And that's not what's best for our patients. So people also say, we hear about these statistics all the time. So what does this really mean? So I want to tell you another story that goes beyond the statistics that we hear. So I want to tell you about my mother. Her name was Sandy. She was a school teacher in Los Angeles. We were immigrants from China, and she made her way to become a second grade teacher in Los Angeles. When I was a second-year medical student, she began telling me that she was feeling run down, that she just wasn't feeling right, that things just weren't quite what she expected because she knew her own body and this just wasn't right. She went to her doctors and her doctors all said, well, this is nothing. You're a teacher, you're exposed to all these kids with viruses. This went on for a year. She began coughing up blood and just feeling really unwell. But she didn't want to be the bad patient. Her doctor had already said to her several times, oh, don't worry about it, you're fine. And she was prescribed at some point antidepressants because her doctor thought maybe you're just anxious. But it wasn't until about a year later that she was diagnosed with breast cancer that was widely metastatic to her brains, to her lungs, to her bones. And she was 48 at that time. The reason I mention this is all along, she knew something just wasn't right. Because she knew her own body, she knew what it meant to feel the way that she did, but she just didn't feel empowered to really say to her doctors what was going on. And she didn't feel empowered because she didn't want to be seen as a bad patient. There's this mentality in medicine where the doctor is the parent and the patient is the child, right? And when you go to see your doctor, you're like, okay, if you say I need to take this medication, sure. If you say I need to get this test done, whatever this test means, sure. And that's exactly what happened. She just didn't feel like she knew how to advocate for herself. And even though I was a medical student at the time, and this happened all the way throughout my training that she went through her illness too, I felt powerless to help her and powerless against this vast medical system that, as Don was saying earlier, really traps us in an unideal system of care. Now, everywhere I go now, as a physician and patient advocate, and I and Josh too, we hear stories of misdiagnoses because it really does happen every single day in our ICUs, in our doctor's offices, in our ERs, in our hospitals. Of the 100,000 deaths that occur every year due to medical error, but the majority of them are due to errors in diagnosis. And we also know that 80% of diagnoses can be made based on your story. 80% based on just hearing why it is that you came in. But if doctors these days are listening less and less, then what does that mean in terms of your medical care? Whenever I talk about this too, and I'm sure later on people are going to ask as well, whose fault is it? Is it the doctor's fault? Is it that doctors are mean and greedy? Well, I have to say that of all the physicians and nurses and nurse practitioners that I've had the privilege of working with over the years, everyone has been very well-intentioned. Everyone wants to do well. You want to do well by your patients. It's a long training, and I don't think anybody goes into this saying, we want to misdiagnose people. And at the same time, patients too. It's not that patients don't want to speak up or patients are trying to do something bad too, right? You just want to get better, but you don't necessarily know how. You don't want to offend the doctor. You don't want to get less than ideal care. My mother was always afraid that if she said something to her doctors that they would see her as the bad patient and maybe treat her less well if she came across as being too aggressive. So where's that line? Patients wonder about that too. And really all of us are trapped in this dysfunctional system. We know that our healthcare system is broken and that a lot is happening to fix it. But how long is that going to take? We know that medical education needs to improve, and Josh and I are both involved with teaching medical students, and that's something very important to us. But can you really wait until the next generation of doctors is trained to improve your medical care? If you're Jerry with your chest pain or Danielle with your headache, don't you want to make sure that you can avoid unnecessary tests and get your diagnosis right now? right? You have to really advocate for yourself and get back to the most basic thing, which is to get to your right diagnosis. So I was talking to Susan earlier and explaining that I started writing this book when I was an intern and just starting my medical training. And I would come back and talk with my mother about writing this book and why it was important and what the things we were doing was. And at first she was like, "What are you doing? You're going to get fired. People are not going to like this. Your patients are going to think you're a troublemaker too." But eventually she started to appreciate what we were doing because it really was something that she felt like had she known these things, she would have been able to get better care or at least felt less confused in the process. Unfortunately, she passed away about 2 years ago. But I know that she would have wanted me to be here and Josh to be here to explain to you about the things that we learned and the lessons that we would want you to know in advocating for better health. And so my takeaways then are the following. First is that patients have to take an active role in ensuring that you get the best care possible. Second, that your story is really important because getting that across is what's going to lead to your diagnosis. The third is that you have to make sure that you get an equal partnership with your doctor because it's with that partnership, not with an adversarial relationship, right? You don't want to be like, "Here, you are misdiagnosing me," but you want to make sure that you have an equal partnership, and that's what's going to lead to the best care. And the fourth really is that what is most important, the person that's going to advocate the most for you is yourself. You know your body the best. You know that nobody else is watching out for you as much as you are. And also that people always say it would be helpful to have an advocate with you when you go to the doctor, right? And so we always say it's important to make sure that you bring someone with you. So we believe that it's the best thing possible to be educated yourself, to be an advocate. And then you can use these skills to help with your family members, your other loved ones who are in need of healthcare in some way. And we really do believe that this is all possible and that all of this begins with you hopefully being here today. And so I want to turn it over to my co-author and mentor, Dr. Kosowsky, but also to once again thank all of you for coming here today. Thank you. And I'll start to pass around the sign-in sheet if you are interested in signing your name and email address as well.
So thank you again. It's a great turnout. It's a pleasure to be here. I wanted to pick up on a few of the remarks that Lena went and sort of move the conversation specifically towards what it is that makes the patient-doctor relationship unique and why we're speaking out specifically on behalf of patients. And I will start by saying that I think we are optimists. We believe that despite all the challenges that we're talking about that are systemic, that have to do with the way our healthcare system is set up, the way our doctors are trained, we believe at the end of the day that our doctors, our providers, and our patients really are looking out for the best interests of the patient. And it's unfortunate that we've put ourselves in this position where doctors and patients seem to be at odds, but as Lena says, doctors go into this business because they want to help people. Just like other providers, whether it be nurses or PAs or other medical professionals. There's one other thing that makes, I think, providers unique in terms of going into healthcare, and that is that they're curious. That it's not just that they want to be helpful, but they really want to solve problems. And when you think about the training that doctors get, we talk about this in the book, going through all the pre-medical requirements and going through medical school and learning all the anatomy and physiology, I get the opportunity to see these students after their second year of medical school, when they've learned all this background and they're sort of set out onto the boards to meet patients, and they are so excited about taking this knowledge and now applying it and solving patients' problems. And we allow them to do that, and it's really a privilege to help them learn how to solve problems and use that curiosity to figure out what's going on with patients. I think diagnosis can be a scary term. People think about, did you get a diagnosis, or what was the diagnosis? People think about, wow, that's something scary. And when doctors use terms like diagnosis or prognosis, I think it puts patients on the defensive because they feel like, well, I have no role in a diagnosis. That's something that doctors can do. It turns out that diagnosis, number one, is something that you require a patient to participate in, number one. Number two, it's not so much a destination as it is a process and a journey. It's not necessarily the case that you'll walk out of every encounter with a doctor with a definitive diagnosis in hand. In fact, most of the time, you don't have a definitive diagnosis, but you have what's called a working diagnosis. You have something that you're working on the assumption that that's the case, or you're working towards this diagnosis, and you have something broader called a differential diagnosis, which are the range of possible things that this could be. When doctors are trapped into thinking that they have to leave you with a particular definitive diagnosis, or if patients feel like that's what they came for and they have to leave with a specific thing, I think that sets that relationship up for failure. And one of the reasons why patients and doctors are sometimes talking at cross purposes is that not only are doctors not listening, but patients aren't allowing doctors to listen. And what do we mean by that? Not to blame patients, but patients need to understand that doctors, and we'll talk about this because it comes up at every session, doctors are working under tremendous time pressure these days. You may only have 5 or 10 minutes with a patient in the emergency department, or 15 minutes at a primary care visit. How can you possibly get all this stuff accomplished in a short period of time? And so doctors tend to revert to sort of shortcuts by asking pointed questions or filling out checklists in order to move things along. But this doesn't necessarily work to the advantage of making a diagnosis. And so in order to foster the better use of that time, we give specific tools and techniques for patients to maximize the use of that time in a very effective way. So for example, if you're going to present something to your boss, or you have a meeting with your congressman and you want to make a pitch for a particular proposal, you will have practiced that, and you will have gotten your story down so that you can tell that story in a short period of time with a beginning, a middle, and an end. How many patients practice their stories before they go to the doctor, right? It's something important, but how many people actually do it? If you start telling a story, we know from studies that the average doctor will interrupt you within 10 seconds of you telling your story. That doesn't give you much time. And that's not to say that it's okay for doctors to interrupt. And we give you techniques to how to parry around those interruptions. But you also have to have a coherent story. We believe that narrative, as Lena pointed out, narrative can give you the diagnosis, or at least lead you in the right direction 80 to 90% of the time. But it has to be a story. If it's just a collection of symptoms and complaints, you're not going to really get very far. And so when I take these students who have learned all this anatomy and physiology, and I introduce them to the wards and ask them to talk to patients, it's remarkable how open they are to listening to patients. And then over time, what happens to these students is that they start to feel the pressure, and they become much more narrow, and they start interrupting their patients, and they start asking these close-ended questions. And they go from being these receptive, curious beings to being these closed-minded, defensive, and counterproductive providers. And so what is it that we're asking of you as patients? We're asking you to give your doctors permission to go back to recall those lessons that they learned about patients being able to tell stories, and reintroduce them to the value of narrative, and allow those doctors, whether it be in the emergency room or your PCP, to really deliver for you and for future patients the best care. We honestly believe that patients can make their doctors better doctors for themselves and for the rest of their patients as well. So I'm going to stop there. We're going to move the podium. We'll take some questions, and we'll be happy to try to provide some answers.
Again, we really thank you guys for coming too. It's really wonderful to see all of you. I do want to make sure that those of you who want to find seats are able to. So I wonder if, okay, so I just want to make sure so that we can engage in a better discussion when we're all more comfortable. So, I think I saw your hand in the back first in the green.
Several years ago, I had a conversation with a neighbor who had trained as a physician in another country, and was making a point that in his training, he was really made to look at the patient and to do these hands-on. And he had walked through with a local hospital, had spent some time with a physician, and he thought there was really an over-reliance on the test, just referring the person to the CAT scan. And he said, I picked up on these signs by just observing the patient, asking some questions. And so he was making a point to me that his training really was sort of more astute in paying attention to the patient per se, and I just wondered what you thought about that.
Yeah, so that's actually so one of the chapters in our book. I might stand because my voice is soft as it is. So one of the chapters in our book is about the training of doctors and about and another chapter is about how we got to where we are. Because we feel that in order for you to know how to make a difference to improve your healthcare, they should also know how things currently work. Right? Because if you don't know how doctors currently think and what happens when you go to a hospital and how doctors are trained, then you also don't know how to make a difference and how to make a change in your own healthcare. And so to your point about the training, that's exactly right. I mean, again, we don't think that doctors are misintentioned themselves, but we think that things guide them the wrong way. And I'll let Josh tell you about his anecdote about medical training. And
I start off by saying that doctors are curious creatures. I don't mean yes, we're also curious. We're curious, but we have curiosity, and a lot of the training that we do actually, in a perverse way, actually beats a lot of that curiosity out of you. You go from taking a patient who presents with a very complex history, and we try to boil that down into some checklist of yes/no questions and then plug that into an algorithm that's going to point us in the direction of this test or that test. So it turns out that actually doesn't require any curiosity at all. In fact, you don't really need a doctor to do that. You could plug that into a computer algorithm, could give you the same results with probably just as good, if not better responses, but in the end you're not going to really get to the diagnosis. I would argue that that diagnosis, like medical training, is a process, and becoming a good clinician, a doctor or nurse, what have you, actually takes practice. In the same way that we ask patients to practice, it takes practice on the part of doctors. And part of our culture, this sort of fast food, immediate gratification culture, is this, I think, misplaced belief that if we can just boil it down into the right questions and the right algorithm, we can somehow get the answer without having to practice and really hone our skills. And you think about how doctors were trained generations ago, and we talk about this in our book, it was much more of an apprenticeship, that you would train with a master clinician, and over time you would develop your skills, you would learn how to pick up on the subtle cues, you'd get better and better to the point where you could actually practice on your own. Well, now, training is so condensed, there's so much to know, first of all, just in terms of the technical knowledge, that this idea that that you're supposed to continue your training and get better and better, people don't have patience for that. Young medical students feel like, I've invested so much, by the time I graduate, I want to be a fully formed doctor. That's really not possible. I tell my students that when the time they finish medical school, if they can get the diagnosis 50% of the time after talking to a patient, they're doing pretty well. And after finishing a residency program, if they can get in the right direction of their diagnosis 80 or 90% of the time, they're a superstar. And then from there, you've got to keep going on. If we set up this false belief that doctors can plug symptoms into algorithms and be able to do it the minute they graduate, we're setting them and their patients up for failure.
And the pressures are not just the training, right? We also talk about the other pressures. There's pressure of time. I mean, doctors really do have very limited time to see you. And it's, I think the 10 seconds interruption is crazy, but at the same time, they really, they're like, I have to look at the medical records, I have to document now with electronic medical records and all the billing. There really is a lot of pressure. And you often hear about the fear of malpractice and defensive medicine that comes from it as well. So I know that somebody might ask about this later, so we'll preemptively address it and just say that, yes, these pressures do exist, but as what Josh was saying, it's so important to give the doctor permission to partner with you. Because if your doctor also wants to do the right thing, right? Your doctor wants to spend time with you, wants to spend time explaining what the reasons are and what are the things that they're looking for. But sometimes they also think that patients want an immediate answer. Right? It goes both ways, that doctors want to give an immediate test, but we hear all the time of patients coming in saying, I have knee pain, I want to know what's going on, I want an MRI. And you say, well, let's wait and see, you rested, and they're like, no, I want to get better immediately. So I think there is that gratification culture, and so it does take that partnership. And what we emphasize in this book is, these are the things that you can do. Your doctor might be wanting to do this anyway, or they might not have had somebody ask this of them, so ask it of them, and engage as an equal partner in your care. Really be empowered to get the best care possible. I think we had some questions on this side, maybe.
I just want to ask you a question. With all the technology today, documentation, check-off lists, pressure, you go into your appointment, are you in the hospital? Who's looking at me? Who's having a conversation with me? And so we see more and more of that in the health field. So how can we feel like the doctor is listening to me when he's at the computer or the nurses?
Yeah, so I think for those in the back who didn't hear the questions, many of the same points that we've been sort of touching on with all the pressures, not only time, but you've got the doctor in front of a computer and you've got many people coming in. How do you even know who you're actually talking to, who you're telling your story to? We're sensitive to that. We work in an academic medical center where routinely you may be asked to tell parts of your story to 3 or 4 or 5 different people. And are you confident that they're all communicating with each other, let alone with you? Can make it even more challenging. We sort of give you strategies to identify who these people are and to make sure that they're talking with each other. But at the end of the day, knowing who it is that's going to be making decisions with you. It may be that you identify a nurse who's a really good listener and engage that person as your advocate. Maybe that's the person who you need to sort of speak for you. It may be the attending physician who is only spending a minute or two going around seeing every single patient, but maybe that's the person who I identify as the person who I need to make sure they get my story. I don't necessarily have time to tell them the whole thing, but they need to understand what my concerns are. Before you leave a doctor's appointment, one of the things that we stress is that the thing that's most important to you, your doctor needs to know. You can't leave that to guesswork. So if you're concerned that, listen, I've had this headache, but my major concern is that I have a brain tumor. For whatever reason, that's what you think it is. If you leave that to guesswork and let your doctor try to guess what you're thinking, the chances are they're not going to be able to guess what it is. So they may go off and order all kinds of tests, but it's not going to answer the question that you have. So a good doctor will actually ask you, what are you concerned about? But if that doesn't happen, it's important that you bring up that topic. Otherwise, you're going to be, again, talking at cross purposes.
So I can add just one really quick thing. A story that a friend of mine told me recently, who is a doctor at Stanford. She was telling me that at Stanford, because when you're a patient, you do see a lot of people. They all dress the same. They wear scrubs. Some of them don't. You don't know who's the doctor, who's the nurse, who's just the registration person, and you're telling your story. And they say, "Don't tell me. I'm just taking down your insurance information," right? So at Stanford, they started giving people baseball cards, giving all the doctors and nurses these baseball cards. It sounds a little bit funny. So bear with me for a second, because there is a point to it. But so now so every time a patient comes in, the first person hands them their card and says, "Hello, my name is Jane. I'm the triage nurse," and they keep that card. And then it's, "Hi, my name is Elise," or whatever. I don't know. I'm the nurse who's taking care of you, and then I'm Dr. Smith. I'm the attending physician. They keep all their cards, and then they can actually remember what the names are. And then when Jane comes in, they're like, "Oh, you're the nurse. You're not somebody else." Because we do recognize that when you're in the hospital or even at your doctor's appointment, it's stressful. Right? I mean, you're already not feeling well, or your family member's in anguish. You don't want to, it's already kind of a confusing situation. And so one of the tips in the book is to always ask, who are you talking to? And then if you seem to be telling this story to one person, somebody else asks different questions, then just ask. I mean, sometimes they do talk, but sometimes they don't. And so it's helpful to see if you get a different response when you talk to 2 different people. Ask why that's the case. Like, you tell the nurse, and she says, "Oh, whatever." And then you tell the doctor says, "Oh, now I'm really worried about you." Why is that? Did they hear something wrong? Did one of them hear something wrong, right? So these are the sort of things that you should flag, because it really is up to you to try to coordinate that care. Again, not the ideal way it's supposed to be. Ideally, your doctor or your nurse or whoever's the advocate is coordinating your care. But in the absence of that, and to make sure you get the best care, at least you can be your advocate in that sense.
Back there.
Yeah. I recently had the opportunity to be an advocate for somebody that was, over the last 3 months, been going to a hospital multiple times, and ended up having 2 different procedures for a detached retina. And it was really interesting, because as you just mentioned, I have a long list on my tablet of all the people that we went through before we got to the person actually making the decisions. And I saw the patient getting very frustrated that said, "Well, I've already answered these questions." And we'd go back a week later, and it would be the same list of questions again. Do you have this sensitivity, blah, blah, blah. Literally the same thing over and over again. Okay. And then what I really like what you said earlier is that the patient has to come in with their story practiced. And I saw sort of 2 sides of us, or dispassionate viewer. I saw the patient not being able to organize the story well. and making the doctor frustrated. But equally, the doctor was withholding, in my opinion, information that would have calmed the patient to say, the diagnosis is not 100% sure for now, but these are the avenues that we're pursuing, and those weren't delineated. So when it ended up that we went down a different path fork than was originally spoken of, it was like, well, where did that come from? And what I saw is this sort of big discrepancy between the doctor, many doctors feeling that, well, they had lots of information, they were very pushed for time to disseminate some knowledge, but in a way they were reluctant to give knowledge, in that maybe the patient didn't understand it or they didn't have time. There's that disconnect between, well, what can the patient absorb, what can they bring in versus the doctor? And then it also amazed me that, well, are there other things that are causing them to hold them back other than just the patient not being able to understand maybe some of what they said? I personally think things can be expressed in a way that the patient can understand it. The first time we went in and they had to go into a surgery, we weren't given any information on the possible outcomes and what would happen afterwards, not even a piece of paper. And then we went in a second time and the same thing. So when the doctor said, well, don't move for 3 weeks, be like this, detached retina. Well, what does that mean? I can't even get up to the bathroom? The doctor couldn't even express that well. And I finally had to sort of jump in and said, well, quantify it. Does not move mean 5 minutes out of an hour you can, or 20 minutes out of an hour, or 5 minutes every 3 hours? It wasn't even down to that level in no piece of paper. So there's still this disconnect between the appreciation and understanding level of the patient and the doctor, and I didn't see the thing meeting at well.
So I think you're speaking to a number of issues, all of which are really important, some of which are pretty subtle, and they have to do with doctors' willingness to give out information. I think as a whole, doctors like to teach patients. There may be time pressures, but it doesn't necessarily take an hour to hit the highlights like you're talking about. What doctors, I think, have a much harder time is communicating when there's uncertainty. It's much easier to say, I know exactly what the diagnosis is, I know exactly what to expect, and here's what to do. Here's a pamphlet I can even give you. But unfortunately, most of the time, it's not as straightforward as that. There is some either diagnostic uncertainty or some prognostic uncertainty, what's going to happen next. And doctors have a hard time talking about that because I think doctors feel, like in our culture, doctors should know the answers. And to have to level with the patient and say, you know what, we don't exactly know. Here are the things we're thinking about. Here's some possibilities. Here's what might happen. Here's what might not happen. I think doctors, I hate to say it, but they need permission to be able to do that. They need a patient who's going to open up to them and allow them to express that uncertainty in a way that is not going to be taken defensively, but taken openly. Like, yes, I want to accept that. I embrace that. I'm going to help you. We're going to work together to get through that uncertainty. Even understanding why it is that doctors ask the questions that they ask. Doctors may come with a long list of questions. Some of them, honestly, may just be, listen, I have to ask these 10 questions because that's what the insurance company requires, that when you come to a primary care visit, I've got to go through this checklist. Great, that's one thing. But there may be one question in there that the doctor's asking for a particular reason that you need to know about, because they're really concerned that your symptom, if you answer the question a certain way, may guide them in a certain way in terms of what test they order next. So you, as a patient, need to know which of the questions that you're asking because you're just asking them a list, and which of them are the ones that are really going to make a difference in terms of how I answer them. So, for example, we tell a story about a patient who comes in with chest pain, and the doctor is thinking, among all the various possibilities, there's something about this story that makes them worried about something called an aortic dissection, a rare but very serious emergency involving the aorta, the main blood vessel from the heart. So the doctor asks about back pain, which is a common symptom that patients who have dissection have. Now, if back pain is hidden among a long list of other symptoms, patients aren't necessarily going to know how to answer that question. Lots of patients have back pain. Back pain is very common, but it may not be the type of pain that the doctor is looking for. But if the doctor asks the question in a way that opens up to the patient, or if the patient says, why are you asking about back pain specifically? Is there something about back pain I need to be aware of? Then you can start having a communication that will guide the next decision in a much more meaningful way.
There is also a way to ask for this partnership. So when my mother was ill, she was in Los Angeles and I was in medical school in St. Louis. But I would go back and visit her. I took a lot of time off during medical school when she was first ill to be with her in her illness, and there would always be things that came up during her appointment that she just didn't know what to do with. Like her doctor would say, take this medication, and she wouldn't really agree. But she just didn't say anything. And I kept on, saying to her afterwards, why didn't you say something to your doctor? If you don't understand, why don't you say something? And she was just really afraid of being that bad patient. And she went so far as to not let me say anything because she was just so afraid that if I said something that I would make the doctor angry, and the next time she would get worse care when I was not in LA anymore. And so, and I have to say, as a physician now, we certainly see a lot of patients coming in who think that they are empowered patients, who are empowered patients, but who probably approach it the wrong way. Let me tell you. So these patients, they print out stacks of information from WebMD, Google all their symptoms. They come in and say, "Here, you are misdiagnosing me. I know myself, and this is what I have. I don't trust you. I trust myself. Here's what I have." And you guys can see the difference between that and my mother, and who didn't ask any questions. Like the right way to be is somewhere not at those either extremes, but it's somewhere in the middle. And there is a way to do that, to be an advocate, and to be an advocate for yourself and for other people. So that involves partnering in the same way that Joshua was just saying, that you're giving people permission. And the way that you do that, an idea is to, one of the ways that we talk about in the book, because we talk about the 8 pillars to better diagnosis, in addition to telling your story, it's also to partner with your doctor. And so you could say to your doctor early on in the visit, I'd like to know what's going on with my health. I want to be involved as an equal partner in coming up with my diagnosis and then thinking about my treatment. So before we do any tests, please explain, what are the things that I might have? What are the things that we are looking for? That gives them permission to be able to say to you that I'm not 100% sure. That's why we have to do some tests. But then they're not just saying, let's do this CAT scan just because. Let's get some blood work. What does that mean? What is blood work, right? What are they really looking for? They should have a diagnosis in mind. That's something that Josh taught me very on in my medical training as well, that doctors always have a diagnosis. This is the way that doctors are taught, that you are taught to think in terms of the differential diagnosis, which is a list of all the possible things that could be going on with you. We learned this early in our medical education training. So doctors are thinking this. Even before they order a test, they're thinking about it. Why not find out what that is, right? Because then you can add to it. So often we hear patients saying, we need to get a CAT scan to look for, or we need to do a CAT scan because of your pain. But what is it looking for? If we said we're looking for appendicitis, the patient might often say, oh, you don't need to worry about that because I had my appendix out 10 years ago, right? So be involved in that process. And if you frame it in a positive way, not as, you don't know what you're doing, but more as, I want to be involved because I know my body and I also want to be involved in my own care, that's a much more positive way of saying it.
That's lovely use of language, and it's nice to have you share the language with the patient. Can you give us some language that we might use in choosing a primary care physician who's already a listener?
Who's already a listener, as
Who
in
is a
somebody
listener,
who,
like you don't know, you're shopping for primary care. So what are some of the attributes that you would look for in that short time that you're sitting across the desk?
So it's a great question, and unfortunately, you don't always have the luxury of being able to shop around. I mean, primary care is in such high demand that you're lucky to just find someone who has an opening on their panel. But if you do have a choice, and maybe it's a primary care, maybe it's a specialist. I think the types of things you're looking for is a doctor who's interested in getting to know you. I don't mean they have to necessarily know all your kids' and pets' names by heart, but they spend some time trying to understand who you are and understand your perspective. It doesn't take much time. I mean, in the emergency room, we don't really have a choice for the most part, and yet even in a few minutes, just the time it takes to sit down, make eye contact, get a sense that they're related to you, not just as a list of symptoms, but as a person. I know these are sort of soft skills, but those are the kind of things that I would look for, and that as a patient, I ask patients to look for. When it comes down to trying to decide, is this a doctor that is going to listen to me or not? Again, if you have the choice, that's great. A lot of times you don't have the choice because you're foisted into a situation in an emergency room or an ICU or wherever the case may be. And what our book tries to teach you is that there are ways that you can take that doctor who may not be a great listener and make them at least good enough that they can give you good health care, and maybe even inspire them to be a better listener for the next patient down the road. I'll give you one example. I have the luxury of training really good residents. We have, the top residents in the country come to train in emergency medicine with us. And when they come and present cases to me, they'll start out by saying this is a symptom, and these are the pertinent positive and pertinent negative aspects of their story. But I always stop them pretty early on, and I ask my resident, I said, so where is this patient from? Where do they live? What do they do? Give me some context. It doesn't take very long to have a sense of who a patient is, or if they're retired, what they used to do, or where their family lives, or something about them that gives you some context. If your doctor doesn't seem to be at all interested in those things, that should be a red flag.
Thank you.
Okay, so tons more questions. Well, should we take some from the back
Here's one in the
to
back.
start with? Yeah.
Right there, yeah.
I have a question. I've been both an advocate and a patient. And something that I've noticed is that when the patient's in pain, it's very, very difficult to become an advocate. And the stories change. And when you have a different doctor on a different rotation one day to the next day, you're constantly having to retell your story. And when you're the patient and your own advocate's not there, or when your information can get very confused. and then that's when I'd be curious from a doctor's perspective about strategies to deal with that, and specifically with sort of then it comes to them diagnosing a pain, a drug to help with the pain levels, and how would you deal with the multiple doctors, the multiple stories, and especially if the advocate's no longer there at that hour.
So you make some excellent points. The first is what you do in terms of being an advocate is so important, right? Because you're basically that bridge for this patient who is in distress, and the doctor and the nurse who may be rushed and so forth. So your work is really important. I think your first point, I'll talk about first, and just so that you guys hear, in case you didn't hear earlier, it's about the importance of, or when you're in distress, it's often hard to communicate. Right? I mean, you already came in because maybe you have shortness of breath and you can't even speak, or maybe you have a lot of pain and you're not in the greatest position to be able to advocate for yourself. So actually, our book emphasizes two things. The first is the importance of practicing in advance. So everything that we're talking about, this patient empowerment and being an advocate, it requires a change in your mentality. Just like it requires a change in the doctor's mentality as well, right? It's going to be uncomfortable for the doctor to explain everything to you. Probably even more uncomfortable for you as the patient to go in and say, I want to be an equal partner. That might not be something that you're really used to doing. And so what we propose is for you to begin practicing it now. First is to practice it in every doctor's appointment, not just when somebody is very ill, because that's not the best time to practice anything, right? The best time to learn CPR isn't when somebody's already in cardiac arrest. It's to learn it well in advance, to practice it. And so make sure you do this at every doctor's appointment, even if it's for a sore throat or a regular annual checkup. But also, we give 21 exercises for what you can do today, even when you don't have to go to the doctor, to think in terms of the empowered patient. To your second point, though, when there are multiple stories and multiple people listening, that's why it helps to write down your story and practice it. And even if it changes every day, practice it. So let's say that you're in the hospital, right? And you have to tell your story on rounds. You know that every morning they come in and the doctors and nurses round. Write it down. Practice it with a family member. Or if you are the family member and your family member is the one that's in the ICU or something, write down what's been going on. And think about, if that person really only has those 10 seconds, is what Josh was saying, if they only have those 10 seconds, how am I going to get my point across? If it changes, that's fine. But write it down every time and practice it the same way that you would practice for a big presentation or for talking to someone, your boss, the exact same thing, because it really requires practice and changing your mentality. Do you want to ask this? Oh.
I don't know the selection process for selecting someone from medical school and all that kind of stuff. My perspective is that you kind of lean on the academics, and I can understand that. It's important to be smart if you're going to be a physician. But in my professional career, if I wanted a particular skill later on in someone's career, I interviewed for that skill at the time of admission. And I think a lot of times your interviewing has been about academics, but not the soft skills that may be necessary to practice the art as opposed to the science of medicine. There are certain skills that cannot be changed, and you must hire them in. Work ethic, judgment, sensitivity. So I think you would be very wise to include those kind of questions in the admission interview if you truly want those skills later on in a practicing physician's life.
So I think that's actually really articulately phrased, this idea that medical education is about more than just being smart. And I know that medical schools are challenged by this, and they're working towards figuring out how can we test for some of those softer skills. They're looking at people who are not necessarily only biochemistry majors, but maybe people who have majored in the humanities, people who have done volunteer work, people who have shown some of those traits of commitment, sensitivity, judgment, empathy.
And the corporate world does this all the time. We do interview for skills we know that will be necessary 1, 2, 3 years out that are not trainable or are very difficult to train in. Work ethic. I've never worked a day in my life, but if you hire me, I'll work like hell. That does not happen. And so I think that, as you say, these soft skills, in a lot of ways, the corporate world can help you in identifying these skills, because that's what we do all day long.
I think that's right. And I know that medical schools are focused on this. I don't know that that's going to be the answer for every one of these situations. And I also know that in the short term, whether the next generation of doctors is more empathic, more committed, more sensitive, isn't necessarily going to affect my next visit to the doctor tomorrow when I see the doctor who was trained 10 years ago. So the skills that we're talking about for patients certainly would be enhanced by having a generation of doctors who are selected and trained for those very skills. But I think at the end of the day, many of our patients are simply looking for someone who's going to listen to them. And yeah, it would be great if this is the most empathic doctor in the world, but there's a certain baseline I can get them up to by following these simple steps. I'm going to give one other example of something that I hear from doctors all the time, which is not to say that they're not empathic, but when doctors run out of ideas, when they're feeling very pressured, what they tend to do is to focus on the 2 or 3 things that first come to mind in their what we call the differential diagnosis. And then if things don't fit into one of those categories, they tend to dismiss the patient, which is a horrible thing to do. But this comes from doctors feeling like, I need to give an answer, and if I don't have an answer, then there is no answer, right? And so I hear residents come to me and say, I'll say, so what do you think is causing the abdominal pain? And they'll say, well, here's why I don't think it's appendicitis, and I don't think it's gallbladder, and I don't think it's X, Y, and Z. So I said, well, then what do you think it is? And they say, well, I think it's nothing. I say, you think it's nothing? It's something. You've got to go back to the drawing board. It can't be nothing. But I think we've trained doctors to think that, again, in these very black and white terms, if it doesn't fit an algorithm, if it can't be dissected and boiled down to a yes or no question, then it doesn't have an answer. And again, part of this is the patients being able to give them permission to say it's okay not to know, but that doesn't mean that we can't keep looking. We can't come up with some broader differential to think about what the next steps may be. The next step may be, let's just watch and wait and see what happens, because it doesn't seem like there's anything too serious. But to say this is absolutely nothing and dismiss it, I think not only does it give the wrong message to the patients, but it doesn't make that doctor a very good doctor.
And we are optimists, in case you can't tell. We do actually think that things are getting better, but I agree with Josh, though. I think that things are getting better, even compared to when I started medical school. I started medical school in 2001, so 12 years, right? And even in that period of time, things have gotten significantly better. So my little sister is much younger than me. She's finishing college now, and she's going to be applying to medical school. And just seeing what they look for in their essay questions, I think things are changing. However, it's not just about the selection. And I think maybe this is, in the corporate world, the same thing would apply too. It's also about fostering those skills in the educational process. And so much of what happens in medicine, still, unfortunately, it's still kind of a toxic environment. Still, there's a lot of medical hierarchy where you're told you have to do this really quickly. I don't know is not an acceptable answer. And if that's all that you're exposed to day after day, I can speak, having just gone through my training. I know that this is what happens. And so this still is a work in progress, but we are optimists that this is something that's going to
I think
change.
it's getting better.
I think it's getting better too.
I do.
But that also means
I'm
that
old enough to remember a lot of that.
yeah, and I do think that younger people and the younger doctors are more willing to have this partnership approach because they are taught it, but you have to also give them permission. I want to ask Dawn how much time we have before we. One more question. I know this lady in the front has been very patient. I'm sorry. Afterwards, we're around to ask.
I just wanted to thank you for a gift because what you said is nothing, and I would add to that nothing important because we've eliminated this, and this, and this. But often when you have these tests ordered, it's so important to know what we're going for. Often a primary who doesn't know will turf you to a specialist. And so you go to the specialist with anxiety, worried, and they do these tests. And a few days later, you get a call, and it's nothing's wrong, and you're still desperately ill. And so, what did I miss in this? You know, they look for one thing. I haven't gotten better. I'm not better, and I hardly know how to go back now and do this. And so, I just think for you to tell me I have permission to ask. You know, what are these tests for? What might they be? And if it comes back negative, thank God, but where do I go from there? Can I come back and can we continue this? That's a gift you gave me because I'll do that.
Well, thank you. I mean, I think this is sort of really ties everything up. I think that when doctors order tests, sometimes they feel like they're ordering tests because they want to make their patients feel better. And there are times where that may be the case. If you're particularly looking for something and the test is required to confirm that diagnosis, it may, in the end, make that patient feel better. But very often, tests can actually make patients feel worse. I'll tell you two ways that can happen. Number one is if you don't know what you're looking for, you're likely to find something. What I mean by that, you'll find something incidental. The tests now are so sensitive. You know, CAT scans can see down to the millimeter. You'll find something. It probably has nothing to do with why that patient had their symptom, but it may provoke even more anxiety that now they found some nodule on your kidney, even though it had nothing to do with why you were originally sent to that specialist, but now you feel obliged to follow up on that. So in that way, it can make patients more anxious. But also in the way you described, if the test is negative, that can also make the patient feel anxious because you go back and say, well, the test is negative, so it can't be anything. Well, again, it is something. The fact that the test is negative may actually provoke more anxiety because what you're really saying is that now we just think it's all in your head because the test is negative, so the test is absolute, you must be wrong. That can even be more distressing to patients. So either way, that if you use a test either to look for something that isn't there or to try to exclude things that aren't there, that's not the right way to use a test. And we talk about the right way to use a test, and that is to help narrow down a differential diagnosis. And it has to be within the context of a partnership with the patient and a doctor for a very specific reason and knowing exactly what you're going to do based on what you find. If you're using tests in any other way, if you find your doctor's using tests in any other way, whether it be a primary care or a specialist, then it's very likely to actually provoke more anxiety.
And it really is about the language, right? You said when you were asking your question about just how things are phrased and what people understand is about how you frame it as well. So that's why we encourage you at the beginning of your visit to say, I want this partnership. And even if it's a doctor that you've known for a long time, just say, I recently have been exposed to this new idea about partnering for my health. How would you feel if I ask you some questions as we go along? I mean, the doctor, it will be a really bad doctor. They say, no, I don't want you to ask any questions, right? They don't really want to do that. So, and then along the way, ask about what is this test for, right? How will it change my management? Every test has risks and benefits. So what are the risks of this test and what is the alternative? Like if I don't get this test done, is that bad? Am I going to die? Or is nothing going to happen? In which case, I might just decide to wait. So we really encourage all of you to take an active step in your healthcare, to play an active role and really be empowered to ask questions, to make sure that your doctor listens to you and gets your story, to make sure that you get the right diagnosis, to ask about every test done, and really in general to advocate for your health because you're the one who really has the power to turn around this tide in healthcare and to really do what's best for you and get the healthcare that you deserve. So Josh and I are very thankful for your being here today, and Concord Bookstore for hosting us. I do want to just let you all know that that we have a number of other events in the Boston area leading into, I think, April or something that's kind of spread out. And so if you have any friends who are unable to make it today, if you can so we would definitely be very appreciative if you could let them know about this and to let them know about our book as well. And if any of you are interested in writing a review of our book, we are very much looking for people to review our book on Amazon and on blogs and whatever else that you do too, mainly so that we can get the word out, right? We need this message of patient empowerment to get to as many patients as possible to build the critical mass. So
just one comment. It strikes me that this would be a book that a medical student should read either prior to entering medical school or to going into their third year.
We have been doing this a lot, so we are also, as part of this book tour, part of what we're doing is going to medical schools around the country. I'm going to Albert Einstein on Monday or tomorrow, and then going to St. Louis and Cincinnati and Chicago and California, and Josh is traveling around the world, in Europe and Australia, just to get this message across, because you're absolutely right. Ideally, we should be educating doctors to get better.
Right.
But in the meantime, there's something that you as patients should do as well, because it really is the partnership for both that needs to happen.
Have you gone to the University of New England yet?
We have not, but local places.
I'm talking with a medical educator from there on Thursday, so I will
let them know about us.
Yep.
And
we're more than happy.
Great. But we will be around to sign books, and again, thank you all very much for your interest and for coming today. Thank you.